Welcome to Brain Wellness, the podcast. I'm your host, Mandy NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So, let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. My guest today is Dr. Kevin Murphy. Dr. Murphy began his career as a radiation oncologist, specializing in tumors of the central nervous system, the brain and spinal cord, with a focus on pediatric patients. He was a pioneer and thought leader in the field of frameless stereotactic radiosurgery in both pediatrics and adults, a technique now used worldwide. The development of PrTMS was inspired by Dr. Murphy's quest to alleviate the symptoms of his son's autism spectrum disorder, as well as the cognitive decline or chemobrain that often plagued his cancer patients after chemotherapy and radiation. In 2017, Dr. Murphy founded PeakLogic Incorporated, and by 2020, he pivoted from oncology to focus full-time on PrTMS and empower physicians worldwide to improve the lives of patients suffering from neurocognitive and neurobehavioral conditions. Since then, PrTMS has been used to treat countless different neurocognitive and neural disorders or deficits, as well as the garnered praise from active duty and military veterans and professional athletes seeking peak human performance. I am so excited for our conversation today. Thank you so much, Dr. Murphy, for being here.
Thanks for including me.
Mm-hmm.
Thanks for the nice intro.
Yeah, so I always make everybody listen to that little bit of a pat on the back while we start the conversation. So we were talking before we hit record, and as you know, I've been in neurology for a long time and kind of focusing on concussion. But this is a little bit of everything, and I know concussion is part of the treatment plans. But I'd like to know a little bit about your story. We kind of talked about it a little bit in the bio, but what brought you to doing all of this work?
Well, as mentioned, my background's in radiosurgery, pediatric and adult brain tumors. And we were trying to find ways to framelessly radiate these tumors and not cause a bolted head frame technique like the gamma knife was doing. That began probably back in the early 2000s period. I was at the University of Chicago and came out to San Diego and started to bring those ideas out here. And we kind of popularized the idea of a thing called frameless stereotactic radiosurgery. And that's the machine. It's a 9-ton accelerator that gives high dose X-ray to a target, moves around the patient, takes about 10, 15 minutes to treat. There's no sensation. The patient gets up and walks out of the room. And the tumor, we assess over a period of months, has very high control rates, maybe like 90% or more control rate. But right around the tumor, when a tumor would die, it would leak out edema and byproducts of sort of being broken down. And that sort of sludge was causing side effects. So the area was gone, the tumor was gone, but the effect was there was some trauma to the adjacent brain. And so I had a master's in neurophysiology, and I was doing EEGs on my patients, electroencephalograms, prior to and then after radiosurgery. And we could clearly see where a deficit was being caused by the X-ray dose itself and also the side effects of the breakdown of the metabolites from the tumor being destroyed. And so the goal was, could I bring those neurons back? Could we restore those neurons and bring them back to life in a sense, make them operate at a better frequency? And that's how I kind of got into this. We got a TMS device and started taking that in our clinic and treating patients following radiosurgery.
Yeah, that's cool. I remember when I was first a nurse doing the stereotactic radiosurgery, and we'd put the people in the big halos and everything. So it's been really fun to watch how medicine has evolved over time, and we no longer kind of drill these things into people's skulls to hold them in place so they can get their radiosurgery. Yeah.
So there'd be a halo on. You put actually 4 screws into the skull, and you would sit there and screw these screws right in your bone. That didn't feel very good, no matter how you anesthetize the patient. Pediatrics really couldn't do it. So the whole field of radiosurgery wasn't available to them because they just can't tolerate having a frame bolted to their head. Therapy I'm talking about helped alleviate that need for a bolted head frame.
Yeah, that's very cool. But so that chemobrain, the toxins that happen afterwards, as a neurologist, I was contacted all the time in the hospital to talk about these patients that had confusion, they had memory loss, they had all these issues with their cognitive function following their radiosurgery. Yeah. So that's where this kind of all came in. What kind of results were you seeing as far as trying to treat that part initially?
Well, usually, these things are multifactorial. So the patient's had a tumor, they've had a surgery, they've had radiation therapy, and then maybe chemotherapy. They've been out of school sometimes for a year while they're going through therapy. So they have a lot of reasons why the system isn't operating correctly. And all those negative things contribute to frequencies of the brain areas going slower. So generally under any trauma, the brain frequency slows down, just like concussion. And the neurons don't go to be dead. They move down at a slower wavelength and become noise. They are not operating at the right frequency. They're sputtering like an engine sputtering, still present, but making noise now. You lose them playing in the band and doing work, and you gain noise. So the goal was, can you move those neurons back up and get rid of the noise and restore their form? And so that's kind of where the principle was. We would seeing in most of these kids with posterior fossa syndrome or a posterior tumor, brainstem tumor, a lot of difficulties, sometimes with ambulation, motor planning, speech. We were seeing improvements really across the board. The main thing was pain control. A lot of these kids were on hospice and we're trying to control their pain. We were seeing great response there, going off their steroids, which was reducing all their sleep disorder and their sugar problems. So a lot of that was depending on where the injury was. We were seeing improvements. And there was clearly cases where we couldn't move the neurons back. There was too much injury. But in general, all of us can have our brains tuned. And anyone with a brain can have their brain tuned. And these kids were having some great responses.
Yeah. Yeah. So what was the purpose of the EEG before and after? I've always done EEG as far as seizure,
Yeah.
evaluating for that. But what kind of things were you looking for before and after surgery?
Well, a couple of things I'll tell you, having been in training brain for 20 some years, is that once MRI and imaging came out, a lot of the EEG analysis became a by-side or a bystander thing. The old days, it's been around for over 100 years, the idea of taking electrical signals from the brain and then looking at that data. When I went through training in the 90s, we were scrolling through ticker tapes of scrolls, looking at little waveforms, and it was very, very difficult to use. It gives you information about the brain over time. Imaging doesn't do that. MRI scans look at your brain, one snapshot, photograph. Is there anatomy problems or not? CAT scan, same way. Is there a bone or blood problem or not? It looks at the anatomy. You can't tell someone's thinking, judging, planning, emotions, memory on those scans. You can see if there's blood flow, like on functional MRIs, as a surrogate for function. What about just function? And you can take that EEG data, and now with new techniques in MATLAB and Python scripts, we can plot that data and show you what your resultant frequencies are at various regions. And then we can tune the brain. We can simply take your brainwave pattern and tune it. Tune it means take out the low energy or the high energy and synchronize the brain at the same frequency. And that's what we've been doing with PrTMS, personalized RTMS.
Yeah. So that was actually going to be my next question. So is that the PrTMS then? Yeah.
I think the RTMS part was repetitive transcranial magnetic stimulation. That's a device that was paddles placed over your head, and you would pulse in a electrical signal, a shock in a sense, to help reset the brain. It was really made as a shock instrument, like a mild shock therapy when it came out 25 years ago. And when I started taking that device, I said, let's make this device a tuning instrument. We don't need to shock the patient. Gs can tell us exactly where to put the paddle, how much energy is required to get the effect, and we can monitor with this over time as we treat and see the brainwaves change. And so P was added by me and us, 15 years ago as the personalized way of doing this by looking at EEGs, successive ones during treatment.
Very cool. Very cool. So how does then PrTMS differ from other standard treatments that we're using?
Well, in standard TMS, again, one location is treated, the dorsolateral prefrontal cortex, and 10 hertz is given, the same frequency, and the system's overpowered. You turn up the intensity till it overpowers and shocks essentially the system, forces the neurons to fire 10.0 hertz. What you find when you do EEGs of patients is that they're not all 10.0. I'm 10.6, you might be 11.2. We all fall in a range, 9 to 12 hertz, but we're not all 10.0. If you give someone their intrinsic frequency or their native frequency, where they go when they meditate, what is their wavelength when they go to their calm place? What's that number? And let's say in my case, 10.6, we're going to add more of that number back to the patient. We're going to give them the same wavelength they're making when they're restful and meditative and copy it. So we're treating the anatomy, not the mind. And a lot of behavioral therapies, of course, focus on the mind, which is important to address. But what about just the physical anatomy? Is the piano tuned or not? Tuned pianos play better. Everyone needs their piano tuned, I can promise you. All kinds of things slow our brain waves down and create noise. Radiotherapy and things like that are obvious, but just bad sleep, head injury, concussion, of course. Neurons respond to those traumas by slowing down. They generally slow under trauma.
Yeah. Yeah. So what kind of things can be treated with PrTMS then?
Well, I joke about this a lot because if you have a brain, you're a candidate. And that's true because we're all on the planet spinning around the sun here with our reasons for having either some stress from work or years of age. As we age, our brain changes its wavelength and sort of naturally slows down. So really anybody, I treat the highest level performers on the planet, from the operators in the DoD to professional athletes, and then we treat autism, and I treat kids with Down syndrome. and cerebral palsy, they all have a brain. And the anatomy has the same format, the same structure: scalp, skull, CSF, gray matter, white matter. It's all in the same order, just like your heart, my heart are the same. Your brain, skull, and mine are the same. And they respond to stimulation very similarly. So in one case, I might treat a operator who is able to shoot better. I might treat a autism kid who can speak better. They'll do whatever they do better if they're tuned, is the way to think about it.
Okay. And how would concussion come into that? Because I know that there is a use for concussion as well. What kind of things would you treat, look for? What kind of outcomes are you looking for?
Well, in concussive injury, you can see the area where the concussion occurred by looking at the EEG. I can tell you how severe it was. Again, neurons will slow down into a delta theta state, which is a sleep state. If it happens in your attention span area, it's hard to pay attention. I have neurons that are sleeping now in my attention span. If my impulse control area has been traumatized and slows, I can't make decisions. I procrastinate. So motor planning might be affected, where the motor areas are slowed and they don't perform. So really, it just depends on where the injury was. We place this paddle over that region and say, wake up. You're not going the right speed. You're over here on the sideline. The band members are marching on the field. You need to be out there. Well, what's their song? They're playing the Star Spangled Banner at this speed. I know the frequency. Here's where you're supposed to go. I'm going to line you back up. In behavioral therapies, you have to ask the neuron to go back. In neurofeedback, you encourage them to go back and reward them for good behavior. Or here's some speed, go back on the field. Here's a stimulant. What we're saying is, I know where you were before you got traumatized. Before the meteor hit the band, you were marching at this speed, playing this cadence on this rhythm, and I'm going to put you back there right now. Look down. Your legs are moving with the band. I'm forcing you to do it. So TMS kind of jumps to the end of the math equation and says, I'm going to place you right back where you're supposed to be and teach you how to line back up with the band and march in place. So it's very direct.
Yeah. Yeah. So you mentioned neurofeedback. Is TMS kind of like a form of neurofeedback then?
Yeah. Think of neurofeedback as being, again, you reward good behavior. If you're watching a video and if airplane's flying and you calm your mind, the plane will fly better. So it rewards you for calming down or for being in a certain state. It's a bit indirect. It requires cooperation. The therapy I'm mentioning to you doesn't require cooperation, as long as you sit in a chair and we have you watch a nice show on the screen, just a nature show while a paddle's placed over your head. Wherever that paddle's placed, it will make your neurons line up and they will march at the speed that we say. And you're essentially forcing the issue. A little more direct and intentional than some of the passive other things that work. I like neurofeedback. Behavioral therapy is great. You also need just to go physically tune the piano.
Yeah.
Let's just go physically say, 4 neurons need to be firing at the right speed and not sleeping.
Yeah. Yeah. Oh, how do you go about doing that? So what does it look like if someone were to do PrTMS?
Well, we come in first, we do about a 5-minute electroencephalogram. It's a wireless Bluetooth picture of the brain. There's 19 different pods that measure your brain frequency. And then we plot that data instantaneously and show you a picture of all 19 brain locations. And you can see the signal, which is the brain speed, and you can see the noise, which is the degree of neurons not firing at the right speed. And we'll see that by location. And then we place a paddle over, I have a computer system that creates a protocol for how to fix that. And we start with a perfect looking brainwave pattern and push the patient back toward what would be, we think, a perfect pattern. And it's all math. It's just a math equation about how do you change the integrals and the size and shape of your Gaussian curve in these areas, and where should the paddle go and how much energy is needed. Every 5 days, we repeat the EEG, and then we change the protocol and adjust it based on the response. So in all medicine, you want to do a dose-response curve relationship. You give dose until you get a response, or you change your dose because the response isn't there. At some point, more dose doesn't matter. It's not a dose issue. And in this case, our goal is to find the patient's dose-response curve for stimulation by looking at by the brain response to treatment every 5 days. And then we adjust that protocol. Outpatient, usually 5 days a week. And for concussion, we probably treat for 6 or 8 weeks, so maybe 30, 40 treatments. It's an outpatient, about 30 minutes a day. Painless, outpatient, come in, sit in the chair, you don't feel hardly a thing. And we just kind of tune those systems, those locations.
So that part sounds kind of similar to the neurofeedback, the 30 to 40 sessions, 30 minutes a day. How, when you're looking at those responses, how do you force the brain to actually go back to that normal setting?
Well, there's luckily physics and a theory of entrainment. So external stimuli applied to the brain cause the neurons to fire at the same rate as that external stimuli. You're essentially taking those neurons and depolarizing their membrane at a certain speed. They have no choice. They will march. They will beat 10.4 times a second, let's say. And you're encouraging them to learn how to get back into their previous position in the band. Neurons don't go, thank you, I'm done. That one time I'm ready. I was 4 hertz, now I'm 10.4. They'll listen and say, you know what, I can't go to 10.4, but I'll go to 5. I'll go to 6 hertz. And they'll inch their way over back onto the field as you teach them how to fire faster. There are neurons that go fast that come down in speed, which happens very quickly. In concussion, the vast majority of is slowing of the system, which you have to bring those neurons back online. And see, it's an entrainment technique. It takes repetition. You can't just yank the brain to make it stay. So I had patients say, I'll do it in 2 days. I said, well, can you train for a marathon in 2 days? What in the world can you do for 2 days and fix a biological system? You got to kind of encourage us and repetitively move the system into a nice pattern. And that takes usually a period of weeks to do that. But there are those that are trying to do this faster.
Yeah. Yeah. Once they're trained, do they stay?
Well, that depends, Andy. I always tell my patients, it depends what you do when you leave my office. For instance, I treat the UFC fighters group. I treat NFL football players, NCAA players. They go back and play football and smack their head and then come back and say, I'm not sure it worked. I was feeling great. And now my head hurts again. So, well, what happened since I saw you last? Well, I was in 4 fights and, got kicked in the head 100 times. Well, maybe that's it. Maybe it's that, trauma. So stop the inciting trauma, number one, and let's not continue in a sport or whatever it is that's causing the head injury, which you'd be surprised. Most of these kids, especially the young ones, are not going to stop. They're going to keep doing that sport. All the hockey players you have in Minnesota, I could take any team there, scan their head, and half the kids are going to have a concussion history, at least, if not all of them. And the current concussion protocols are very simple in a way that are requiring the patient to tell you how they feel. The EEG goes beyond that. Patient passes their concussion protocol and I show them their brainwave and say, you're still concussed. I have your pre and post. I can see, here's your brainwave pattern now. Here's where it was before you were hit. It's clearly still concussed, right? Well, they want to play and they want to get back on the field. So they're going to tell me, doctor, on one hand, I feel fine. And then when I expose that and show them their brainwave pattern, they say, well, yeah, you're right. I mean, I'm photophobic. I have a headache. I can't sleep. I'm taking Adderall, that whole thing.
Yeah. Yeah.
So how you treat your mind, your brain. If you go and you cooperate and stop damaging, most of this is semi-permanent. You're moving the brain back to a more stable state, a calmer state. You're copying their rhythm when they're calm, and it tends to be durable.
You mentioned pre and post. Are you getting baseline data on people?
Yeah. So when I have teams that I work for, like in the NCAA, I'll scan the entire team, have a baseline, and that there's a suspected injury, then we'll look at their post scan and say, let's look at these two side by side, and we place the waveform side by side, and you can see clearly where there's been disruption. And also when they're ready to go play again, I can release kids to go play again. I can tell you, Mandy, the thing that's the biggest problem beyond the unreported incidence of head injury, because it's highly underreported. CAT scan's fine, CT's fine. There's no evidence of, blood or a skull fracture, so they're sent home. The brainwaves aren't fine, and they don't record. Just come back online and march with the band again. It's the second and third concussion, which is particularly damaging in these cases where they weren't diagnosed. They went back and smacked their head again, and now a very unstable system that wasn't balanced got hit again and went even further offline and got more unstable. So unbalanced systems really don't like to be challenged another time. Take a wobbly spinning wheel on my desk and tap it, it falls over. Take a tight spinning wheel and tap it, it just moves over and keeps spinning. So you can make people concussion resistant by fixing their brainwave pattern. That hit will bounce off them. An unstable system is at risk for a further injury that's more difficult to manage. And the part of the brain that is the most deleterious in concussion is the posterior part of your brain, back of your head. So back of the head injuries are the most difficult to manage because that's what drives the rhythm from back to front. Mm-hmm. That's where the waveform begins. It's like a rear-wheel car driven car where you knock out the drivetrain when you damage the back of the brain. So you'll see patients with posterior head injuries having more symptoms and more difficulties.
Yeah. Yep. And, when they get hit in the back of the head too, sometimes they have that rotational force. Does that rotational force then show up at all in the scanning where it doesn't show up in any other image?
Well, some of the shearing injury that we would see in the white matter tracts from, like, let's say a high impact head injury still reflect themselves ultimately as a change in frequency. So think of the anatomy of an MRI showing you, are there track changes? You might see them. But really, at the end of the day, is the neuron firing or not? Is it too slow or not? What is the end of the math equation? How's it behaving? Is the engine timing off or out of cadence or not? And that's really what matters the most. So to me, for ease of treating patients in the clinic, I want to see the end of the equation. Show me what the system looks like after your age and your history and all the things you've been through, what it looks like. So yeah, I think in posterior head injuries, particularly, really find trouble with restoring some of that waveform because the driver of the rhythms is the problem. And they'll have vision trouble and all the things you expect by posterior head injuries, photophobia. But I've had patients change their prescriptions and go off their, pain meds and also some of their migraine meds by fixing that posterior rhythm.
Yeah, and that makes sense because we put all those medications on there as kind of a Band-Aid to cover up the problem, but we're not really fixing the problem. So I like the idea of actually correcting the underlying thing so that they don't have all of those symptoms. And that's
Yes.
where I think we get lost a lot. So I like the idea of doing the pre-post. I kind of wish we could do that on everyone. I know a lot of the schools are using the impact testing, but that can be very subjective too, just like the rest of our symptoms of concussion, because many students have figured out how to kind of dodge the system by not performing their best on the pre-test so that it doesn't show up as well on the post-test. But this is one area that you can't really fudge that.
That's true. I mean, we tell people it's a vital sign.
Yeah.
So there's no brain vital sign. What I wanted to do when I first started this process was create a brain vital sign. Why can't I look at the brain state and look at one picture, not 34 pages of gobbledygook and an EEG analysis? Show me a picture of the brain, all 19 locations. What is the frequency and what is the noise, period? And is the neuron system, front, middle, and back, lined up on the same frequency? Is the orchestra tight? Is the music clear? Is the signal quality good? Or is there noise in the system? And that's really what this does for us, because it's a one picture view of that. And we see the whole brain on one setting. Very clear to put them side by side and see differences from an injury. Can't fake it. It's math. We just plot the math. It is what it is. When you went to your calm mind, you did or didn't go to that place. You have noise in that system or you don't, but you really can't deny it. It's kind of a nice vital sign. It's very objective.
Yeah, yeah. And I think I remember when we connected last time, you talked about it being useful for migraine also. So that's
Yeah.
another population I see quite a bit. How would you do things differently for migraine than brain injury, for
Well,
example?
what we see in migraine patients are the temporal processing regions, which are these areas of over your ears on both sides, tend to be very heavy and slow with the delta theta wave, very, very sleepy temporal processing regions. Right behind that, in the parietal areas, it's very clear often, very low amounts of delta theta wave. That discrepancy between those two regions is really consistent with patients with a known history of migraine, or they have propensities for headache. And as we treat the motor sensory strip, we treat 4 or 5 locations every day. The motor sensory strip and the temporal processing areas get treated, and we watch those delta theta waves go down. And when you reduce the amount of delta theta in the temporal regions, their headache goes away. I'd say about half our migraine patients will lose their migraine. The other half has some response. About 20% have little to no response, where it's not going to fix. So some migraines caused by bruxism and TMJ and other issues that patients have with stress, that tends to respond very well. In head injury, you've had a physical movement of those neurons down due to a trauma, and it might take more time or some recurrent treatments to get those areas to thin out on the scan.
Yeah, I was gonna throw that out there. So what if you have somebody that has complications, like they had a history of migraines and now they have a head injury and they have new headaches now too. So they got kind of all three things going on.
Well, again, I always say first, let's stop the insult. Whatever the insult did that got you here, it might be triggered by certain things, by even, barometric pressure can affect patients, seasonal allergies, all kinds of things. In most patients, it's idiopathic. We're not sure why they have a migraine history, whether it's vascular or, multifocal ocular type migraines. The bottom line is headache pain can be reduced by undersampling the pain. Most patients with chronic pain oversample their pain, meaning they think about it constantly. You want to turn down the frontal cortice areas that sample, is my knee hurt? Is my knee hurt? Is my knee hurt? If I think about it every 4 hours, not every 4 minutes, it hurts less. And if I ask those patients, is your knee bad? Oh yeah. Now that you ask me, it hurts a lot, but I haven't thought about it for 4 or 6 hours. And they'll stop taking their pain meds because they're not self-medicating. So a lot of this just depends on the severity, the location. Are they going to keep doing an inciting negative thing? Sometimes it's hormonal, and the hormonal system is fighting them, and we have to address the hormone situation. And that can be anywhere along the HP axis in the pituitary, or it can be at the FSH-LH and the estrogen, progesterone changes. So really all that's in play. On the scans, they have a very similar appearance, whether it's concussion or hormonal or whatnot. You see slowing in areas that are in the temporal processing regions and thinning out of the parietal areas.
So then is there anyone who shouldn't do PR?
Well, although I think it's fantastic for some cases of psychosis, because I have seen benefits in these patients, it can be hard. You can have more of a manic episode create in bipolar. If they're in a manic episode, we don't treat them. It is brain stimulation. I think in some of my autism kids and some kids that have a very slow front cortex, when you turn that area on, it's like shaking Rumpelstiltskin. It's like this area's been sleeping for years, and you just say you're going to wake up, and the system's like, but we're not a really formed, well-developed area, and now you woke me up, and so you can see some irritability in some of those cases. I always tell parents that's a great sign. The area that I'm trying to wake up is waking up. It won't start speaking Shakespeare the first time it opens its mouth. It's going to make noise and babble kind of like a baby does. If I treat the motor sensory regions or Wernicke's and Broca's region, I'm trying to activate their speech cortex. I won't expect them to have fluent language. What I want is that the system tries to learn how to make noise and talk. So yeah, you can see some of these temporary things when you activate the brain regions, but really there aren't many contraindications to treatment. It's such a mild stimulus we're giving. Your brain's electrical, and we're getting electrical stimulation. So the same medium it operates on, the same fuel supply it's using, in a sense, we're adding to that. Drug therapy doesn't do that. Drug therapy isn't that generally native to the brain in many cases. And so this is more, I would argue, in line with the brain's natural way it manages. Sorry. So good question. Yeah, that's asked a lot. And I think, depending on the severity of injury, it might take 2 weeks to treat somebody. It could take 6 weeks. Depends on my autism kids I treat for months. And some of my cerebral palsy kids, I treat them for months. They need more treatment.
Yeah. Still 5 days a week for months when you're doing it that way, or is it less
Yeah,
often?
sometimes twice a day.
Okay.
It's like physical therapy for your brain. You could argue, I'm done. 2 weeks, I feel good. Don't need more. We're done. I treat pro golfers and they want a small little tune-up and they start playing better, putting better, sleeping better. They don't need much. And then I have kids that have brain tumors where there's missing parts of their cortex, and we're going to have to take more time to try and restore those areas.
Mhm. Yeah. So I think the next kind of big question for some of my listeners is going to be, is this something that's covered by insurance?
For MDD, major depressive disorder, it is. Migraine is also covered, and so is OCD. So those are 3 coverage areas. It's getting more and more popular in autism, PTSD. I think you'll see the next coverage come out. There are lots of us working on concussion. I have a retrospective data set on concussion. I've treated thousands of patients with concussion. We have 2 studies being done at a big university coming up here this year, funded by the Department of Defense on mild TBI, concussive injury. So that's going to hopefully be one of the next ones that gets the approval through TMS, or at least on that top list of those that might be added to it. But right now it's major depression, which a lot of concussion patients might have. So if they have concomitant or comorbid MDD, then you can approve them for MDD and also treat their concussion while you treat them for 3-MDD. And that's something that we see quite a bit with PTSD, for example. They have concomitant major depression disorder, and we get them approved for MDD, but also we're treating their PTSD while we're treating them. So
I was going to say, when you give that list, it's kind of all the things that happen to concussion patients anyway. So
yeah.
Yeah.
And I mean, how you got depressed, it shouldn't matter. If you're depressed, you're depressed. So it's certainly, when you slow neurons down, it creates physical depression. The heaviness your patients feel when they describe how the brain's operating makes complete sense when you see their brainwave pattern. Areas that do thinking, judging, planning have been slowed. How do we all feel when that area slows? We can't think, plan, judge very well. We have brain fog, right? I have brain fog too. If you wake me up at 4 a.m. and say, let's do some math, I'm like, I'm not awake yet. Well, what if I stay at that frequency all day and I don't wake up? That's how they're feeling. They're living in a sleep state. So you got to wake those neurons up, period. And that's what we're trying to do is move them back on the field.
Are there other ways to do things like this, or is this kind of the only way that we have to force those brainwaves to wake up?
Well, if what we're doing is taking a meditative state and copying it. So if you could practice meditation, that'd be another positive thing to do. We're just kind of cheating and saying, when you meditate, I know your frequency. Here, I'm going to make you do it. I'm not going to encourage you to do it. I'm going to force you to make your legs move with a band. So it's a little more direct. So I think, though, that meditation practice and so forth is great to go along with it. Stimulants are what we treat a lot of these patients with. I don't, but lots of doctors say, well, how do I wake your brain up? Here's some speed. The problem is the whole band gets speed. You can't pick and choose who gets it. It's called a side effect. So some neurons are like, I don't want speed. I'm over here freaking out, going fast on the sideline. I'm on the other sideline. Don't give me speed. And the guys in the marching in the band are like, we're fine. We're out here marching, but we're over here playing. We don't need speed. No, you're all getting it. I can't choose who gets it. It's called a side effect. That's one of the ways you wake up systems. You just give them a stimulant.
Yeah.
If you electrically move them up, they don't need a stimulant. The same stimulant causes a paradoxical effect in them because the system's already awake. So they'll self-medicate less with those stimulants if you fix their brain pattern.
Yeah. Yeah. What other things would you do alongside of this? Or are there other recommendations you give to patients while they're doing this kind of treatment? Is there anything they can do to help it work better, faster, something like that?
Yeah, well, I think All cases, if you look at any neurobehavioral, neurocognitive problem across the board, sleep is probably the biggest comorbid condition that patients are having trouble with sleep. So light therapy in the morning, no glasses, no contacts, outside, an hour between 8 to 9 o'clock in the morning. Across the globe, generally second, third hour of sun, of light, not the sun itself. So being in the shade is fine. You need natural exposure to sunlight at a 450 nanometer to 550 nanometer blue spectrum to get your retina and your HP axis to activate and turn on. It also suppresses melatonin at that blue frequency. That's why you don't want it at night. You want it in the morning. If you get it at that time, you make a burst of melatonin 12 hours later when that suppression of melatonin wears off. And that's what puts you to sleep in deep sleep. Deep sleep is gotten by getting morning sunlight. Try and convince patients of that. Get morning light and you sleep better. How does that work?
Yeah, that's kind of cool.
The suppression takes 12 and a half hours and then wears off. And then by 9:30 at night, you're getting sleepy. You got about 30, 40 minutes to take advantage of your brain's own burst of melatonin. If you do and go to bed during that period, you go into deeper sleep. If you don't and you get your second wind, you're kind of screwed. Your brain's like, you had a chance. I was going to put you down at 9:30. You didn't take it. You watched your show. You stayed up late, and now you're wide awake, and it's midnight, and you lost it. We'll see you tomorrow. Get light. We'll talk 12 hours from then. One chance every 24 hours to set your clock. You can't fake it. You can't change it. Night shift workers are never going to have good quality. It doesn't work that way. All your generations of ancestors got morning light and went to bed when the fire burned out. And we can't change that. The genes in our retina are programmed based on the light frequency that occurs during the blue spectrum during that time of morning. And you got to get about a half hour to an hour of exposure to it. And it won't go through lenses like this or contacts. So you have to put these down like this, sit on your patio like this.
Yeah.
So you're getting exposure.
Interesting. Yeah, I talk about sleep all the time with my patients, and I had one patient that we talked about all the different things he can do, and he was not sleeping great. And finally I said, okay, do I need to write you a prescription to tell you to sleep? Because if you do nothing else, you need to sleep because that will help your brain. He said, okay, I'll write that down.
Yeah, it's a key element. I mean, we everyone knows it. We know how great we feel when a good night's sleep. We know how we don't feel when we don't sleep. So there's no mystery. The brain every 24 hours needs a certain amount of delta wave sleep. You get delta by getting light. You get light by getting out in the morning. And in Minnesota, it's hard. Like, what are you going to do? And it's winter there. You use these light boxes like I've got here. And this is a little light box on my desk that gives me the same wavelength and allows me to be inside and not miss that light exposure.
That's a really good idea. I've heard those used for just the satellites in general for people that have emotional issues in the winter, but I hadn't thought of it for just getting that light in the morning. That's a good.
Yeah. I mean, it came up popularized by seasonal affective disorder, SAD, which is the same issue. During the wintertime months, patients would have more depression because guess what? They don't sleep well. Why don't they sleep? They're not getting exposure to light.
Yeah.
And so if you go anywhere on the globe and go out of the higher elevations, as you get on the globe, you get less and less light exposure. And you see rates of depression go up and alcohol and self-medication go up as you get in those.
Yeah.
So you're definitely.
Yeah. We get up and we go to work before the sun comes up. So there is no option to get that sunlight.
Yeah. People are in their cars and they're driving and they don't get it because the windows block most of that light. It's very, very weak frequency of light. The blue light spectrum is actually pretty weak. It won't transmit through these little cheater glasses. It won't transmit through. But I think contact lenses are a real problem. Patients don't realize they're blocking their retina when they do that. They go outside with their contacts on. The retina's like, is it 8 o'clock? Is it 8:30? I don't know. You keep blocking that frequency of light. I can't tell what time it is. So I tell them, take out your contacts, put your glasses on, do this, and do whatever work you're doing outside so that light hits your retina and starts that process.
Yeah, that's interesting. I wouldn't have thought of that before either. So very cool. Very interesting. Where can people find you if they want to learn more about PrTMS, if it's something that they can do?
Yeah, PrTMS.com, PrTMS.com is probably our best site. They can go on there and I've got a link tree on there and all of our papers are on there, testimonials and so forth. We're in about 25 states and maybe 70 or 80 centers using our software. And it's a software that, psychiatrists, neurologists, primary care doctors will license from us and then they treat their patients with our protocols. And so it's been very successful and we're happy to, take questions from folks that might be interested. And there's a place on that website to go to ask questions and we can respond to you.
Perfect. Awesome. As we wrap up then today, any last things you wanted to share or any last little pieces of wisdom?
Well, I would just tell everyone that, it's an unmistakable problem that, your no fault of your own are going to have frequency issues that probably could be addressed. And I think the stigma has to be taken away from this and turned into it's a brain thing. If my attention span area is flat and this area right here on these kids come in on their ADHD and there's no energy there, they can't pay attention. By definition, it's very vindicating to see your brain and go, well, there it is. My impulse area is really fast. I'm impulsive. Well, yeah, because the area that does that function's overfiring. I'd be impulsive too if I had that area firing as fast as yours is firing. That, I think, starts to take away this self-loathing. Why am I having these problems? Why is it a me issue? No, it's a brain issue too. Like the piano's not tuned. It doesn't play right. You can't help it. Let's tune it and then see how you play. You still need a piano teacher and a good set of music and practice, but you got to also fix the anatomy. And this is what we're trying to do is let's tune the anatomy as well. Make sure it's not out of tune.
Yeah. Yeah. I think along that line, some people tend to think that they're almost a failure at things and they can't do things. But when they see it, that it's a brain function thing, then it does kind of give that little vindication of that.
Yeah. It takes away some of the self-loathing. Like it explains their behavior and why they've had struggle with certain things, that the area that does that functions is not behaving properly.
Yeah. Yeah. Good information. Thank you so much for being here today, Dr. Murphy.
Yeah. Thanks for having me. This is great.
Yeah.
We'll talk soon.
Okay.
All right. Take care. Thanks.
Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.